And next I'd like to call up Denise Martins.
Okay, good afternoon. My name is Denise Martins, and I am from Canada, from London, Ontario in Canada, and I am the ALS clinic nurse at University Hospital. This afternoon, I would like to talk to you about the advancing respiratory care in our ALS clinic. I have no disclosures. My objective today is to discuss our clinic's respiratory management model. I will talk about how we provide early intervention of respiratory support for our ALS patients and how we ensure our ALS patients are getting the most effective respiratory care available. Some background. There are 3 available ALS practice guidelines. The first is the American Academy of Neurology Guidelines. This respiratory guideline includes to initiate non-invasive ventilation for patients with orthopnea, sniffed nasal pressure of less than 40 centimeters of water, or FVC, forced vital capacity, of less than 50% of predicted. Then there is the European Federation of Neurological Societies guidelines. This respiratory guideline states to initiate NIV based on respiratory symptoms and 1 abnormal respiratory test. The test results they consider are SNP, less than 40%, or upright FVC, less than 80%. Thirdly, there is the National Institute for Health and Care Excellence guidelines. Their respiratory guidelines suggest to initiate NIV with an FVC less than 80% with symptoms or less than 50% without symptoms. As you can see, there are a number of gaps within the current guidelines. Our clinic initially used the AAN guidelines, but we felt we were initiating NIV too late when we followed these guidelines. We then started initiating NIV earlier and found that it improved our patients' acceptance, their tolerance, and ultimately their prognosis. We also find that using both upright and supine FVCs are very helpful as a screening tool for assessing our patients' needs for NIV. Our ALS patients are screened for respiratory involvement at each clinic visit. Clinic visits at our clinic are generally every 3 to 4 months. When reviewing the symptom history with our patients, we ask about shortness of breath, whether it's on rest or with exertion. Exertion may be simple things like talking, eating, or even transferring. Orthopnea, early morning headaches or confusion, excessive daytime sleepiness, cough strength, or vocal projection ability. Sometimes poor speech is because of respiratory insufficiency rather than dysarthria. Our pulmonary function screening consists of supine and upright forced vital capacities and capillary blood gas, which is taken from the patient's earlobe. A technologist takes a small blade, lances the ear, and expresses blood into a tube. Capillary blood gases are much more comfortable for our patients compared to the arterial blood gas draws, and they are similar in their accuracy. If our ALS patient has any of the following features, then we refer them for NIV initiation. Shortness of breath at rest or with minimal exertion, breathlessness lying flat, FVC less than 70% of their predicted, reduction in forced vital capacity by 20% from the upright to supine position, or hypercapnia, which is a PCO2 of greater than 45 in their capillary blood gas. If our patients are experiencing any of these features, then we would immediately submit a referral to our clinic respirologist, and we would initiate paperwork to request provincial equipment. This requires a patient's signature and confirmation of their eligibility. In Canada, we have a publicly funded healthcare system that is provincially administered. This means that each province will have different criteria for the provision of respiratory equipment. In Ontario, where we are situated, All patients living in private residence will have access to NIV and cough assist machines through a ventilator equipment loaning pool. Unfortunately, patients living in nursing homes do not have consistent access to the same equipment. We are constantly navigating challenges with patients living in nursing homes and their access to this equipment, as well as the training of the staff at these facilities. If we have patients who have urgent respiratory needs, then we can provide them with loaner equipment that has been donated to us by the ALS Society. Patients use the donated equipment until their machine arrives from the government, which usually takes 3 to 4 weeks after the paperwork has been submitted. Here is the algorithm we use for NIV and cough assist initiation. On the right side of the diagram is the pathway for NIV initiation. The left side is a pathway for cough assist initiation. I don't expect you to read the slide. We will talk about the process on the next slide. The NIV initiation occurs at our hospital in the outpatient clinic. It is a 3 to 4 hour appointment for our patient and their family with our respirologist and respiratory therapist. The NIV machine is trialed on the patient in a reclining chair. The patient is encouraged to nap with the machine on to see how well they tolerate it. Titration of pressures and backup respiratory rate are done by our RT according to the patient's comfort. Patients are given information on various masks available and how they can obtain them. Patient and family are taught about the NIV machine, how to adjust the humidity, and basic cleaning of the machine and its parts. Once the appointment is finished, the patient is sent home with their own unit. Patients will then receive a home visit from the community respiratory therapist within 2 weeks. Patients are encouraged to contact our specialized respiratory team for troubleshooting at any time between their visits. Our specialized respiratory team can troubleshoot with patients over the phone or have them come in for appointments as needed. Our specialized respiratory team sees patients every 3 to 4 months on the same day as our multidisciplinary clinic visit. Patients with self-reported impaired cough are taught lung volume recruitment and manual cough assist by our ALS clinic physiotherapist. If the patient's peak cough flow is less than 270 liters per minute, then mechanical cough assist is initiated by our respirologist. Paperwork is submitted to the government for the cough assist machine, and like the NIV, we have loaner equipment from the ALS Society that patients can use if they need the machine urgently, until their own arrives, which takes 3 to 4 weeks. The cough assist machine teaching is provided by our ALS clinic physiotherapist. Our physiotherapist will also review techniques at each team visit and is available to patients in between their team visits for support and to troubleshoot. And this is our algorithm again. We encourage our patients to have a pneumococcal vaccination every 5 years and a seasonal flu vaccine annually. Likewise, we encourage the caregivers to get the seasonal flu vaccine as well. Patients with significant respiratory insufficiency or at high risk of aspiration pneumonia are provided with a prescription for the antibiotic levofloxacin. Patients are educated about symptoms of pneumonia and instructed to fill this prescription and start using it at the earliest symptoms of pneumonia. We realize that with this method, we will be treating several viral infections, but we don't want to miss or delay treating a bacterial pneumonia. Patients are encouraged to use their cough assist techniques either manually or machine on a regular basis and to increase the use if they have an upper respiratory tract infection or cold. We like to see patients use their cough assist machine twice a day, but at a very minimum of every morning. We regularly talk with our patients about their sleeping postures and positions and provide suggestions and ideas to improve respiratory function at night. For example, we talk about sleeping on wedge pillows, adjustable beds, or even sleeping in a reclining chair. We ask patients to contact our clinic if we are experiencing significant changes in their respiratory symptoms or have questions or concerns about their breathing. Patients really seem to appreciate having this open line of communication with our team. We find it important to have frequent conversations with our patients about the respiratory interface they are using with their NIV. For example, some masks may be uncomfortable for patients and may cause pressure sores, particularly when they are requiring the NIV device for longer periods of time. The DreamWear mask, seen here in the picture on the left, is a smaller mask that is placed under the patient's nostrils with a band around their head. This mask allows patients to talk and eat while on their NIV. Also, it allows for unobstructed sightline for watching TV or using electronics. The Amera mask, seen here in the middle picture, fits over the patient's nose and mouth and has a band around their head. This mask also has unobstructed sightlines, and the pressure points are lower on the nose compared to a standard mask. The scuba mask, seen here on the right, is a larger mask that fits over the majority of a patient's face. We only use this mask temporarily when there are large issues with pressure sores on the nose that are not healing. Currently in our clinic, we have 141 ALS patients. Out of the 141 patients, we have 49 patients on respiratory support NIV and 6 patients that are invasively ventilated. Our clinic patients are satisfied with their respiratory care and support they receive through our specialized respiratory clinic. Compared with prior to initiation of the specialized respiratory service in 2011, the patients in our clinic are living longer. We can now maintain patients on NIV for greater than 20 hours a day for even up to 3 years, compared to previously, patients who were on NIV for greater than 16 hours would be changed to invasive ventilation or palliation. Several of our patients on extended NIV for the majority of the day have excellent quality of life. Our patients really appreciate having access to specialized respiratory services via phone or email in between their clinic visits. For our patients that live remotely from our clinic, we're able to monitor their respiratory support through modems attached to their NIV machine. We also do intermittent visits via telemedicine service. In closing, I want to highlight some of the aspects of respiratory care that are important and may be different than other clinics. In our clinic, we provide tight integration of respiratory care for our ALS patients. Our respirologist sees patients as part of their multidisciplinary team day. We initiate NIV for all patients with FVC less than 70%, regardless of their symptoms. We feel it's important to use upright and supine FVC in the respiratory screening of our patients and feel a drop of 20% is evidence of respiratory weakness. We also promote aggressive use of cough assist techniques. As well, we feel that it's important to prescribe a prophylactic antibiotic for early symptoms of pneumonia. As a clinic nurse, a big part of my job is to ensure patients have frequent health teaching around respiratory care. The patients really appreciate the access to respiratory troubleshooting between visits via phone or email. Respiratory care of ALS patients is of the utmost importance. Early intervention of NIV and cough assist is extremely important for patients' outcomes and allows our patients time to adjust, therefore ultimately maximizing the benefits. Provision and support of respiratory care by a specialized respiratory team is key to excellent patient care. Please stay tuned as the Canadian ALS Best Practice Guidelines are currently being developed. These guidelines will include several specifics about respiratory care. We look forward to their completion in the near future. Thank you.
Thank you. We do have time for a few questions in the front.
I'm Teresa. I'm from New York. And I'm just wondering, when you start the patients early, are you starting them during the day or at night? Like, do they use it
So,
daytime or nighttime?
good question. Generally, we'll suggest to them to, if they nap in the afternoon, they start by using it during their nap in the afternoon just to get more comfortable with the mask, and then at night. They transition from the nap during the day and then overnight.
Thank you very much. Great work. This is what we really want to see happening.
Yeah.
I have some observation that not just ALS patients, people who are reaching the 50 and the 60 years of age, both men and women, tend to have mucus in their throat. Mm-hmm. And they have a little bit like asthma, but it's not real asthma. It's like a little allergy, so asthmatic kind of reaction. And those mild symptoms can be relieved by taking an Epsom salt bath, which has magnesium. And that brings to the next question. Could ALS patient, in giving magnesium, help reduce the asthma-like symptom and the breathing difficulty at night? That can potentially be a possibility. We have some earlier evidence of that. So if that can be explored together with the early intervention with using BiPAP, that could be even more beneficial.
Yeah, that's great information. That, for sure, going forward, that would be something we can look into. Yes, thank you. Thank you.
Okay, over here.
Hi, I'm Joanna from Louisville, Kentucky, and we do a very similar respiratory at our clinic as well. But one of our biggest problems is nursing home and also transitioning patients from NIV and Trilogy, Astral to hospice. Do you guys have any problems with that as well?
Yeah, we do. So we're working, like I said, with the nursing homes because that's quite a problem. Right now, the government won't allow you to take your machine with you there, so then we have to look to get the nursing homes to either buy one for the patient. But for hospice, it can be an issue depending on the area because we cover different areas, different hospice. So once again, it's something we're working with them on, but it does become a problem, yes.
More of a comment than a question. Rebecca Axline from Houston, and we've run into some of the difficulties with the Trilogy as well in hospice, but we work real closely with our respiratory services, and they work with contracting. They do a lot of that footwork for us so that we provide, we use the facilities and the hospice agencies that will contract with our respiratory folks to get our folks the better machines, the Trilogies.
Great. Yeah. Thanks.
Hello, I'm Patricia from the University of Virginia. How do you teach patients and caregivers to use the cough assist?
Sorry, can you repeat that?
How and what do you use the patients and their caregivers to use the cough assist?
So the patients, if the patient can't, the caregivers are trained as well to use the cough assist, whether it's manual or mechanical.
Right, but do they come in to learn to use the non-invasive ventilation? Or do they come in to learn to use the cough assist?
Yes, the physiotherapist, with the physiotherapist, yes.
Thank you.
Hello, my name is Angelica from Jacksonville. I just have a question. You mentioned that the satisfaction of the patients improved. Do you use any particular scale, or was it just an interview process?
Just an interview process, yeah.
All right, if there's no one else, thank you very much.